التوبيك الثاني هو الشورت ستاتشر. برضو حاجة من الحاجات اللي احنا as general pediatricians بقينا نشوفها common جدا. حتى كتير من الأهل بيبقوا جايين just عايزين يطمنوا على growth of their child. Is he okay or not? هحاول أجاوب على السؤال دوت. هل الشورت ستاتشر that simple ولا ممكن يكون وراه حاجة مهمة أو dangerous? The first question is why growth monitoring? The importance of growth monitoring is that growth is a general indicator of a state of a child's health. Short stature is a relatively early sign of poor health. And short stature is the most common complaint that brings the child to a pediatric endocrinologist. And there are factors affecting growth. We have intrinsic factors and extrinsic factors. The intrinsic factors include genetic factors, which are very important, and hormonal factors. The extrinsic factors include exercise, nutrition, and socioeconomic factors, and of course, both factors are interconnected. So, what is the definition of short stature? It's a height below -2 standard deviation for age and sex, or height below 3rd percentile for age and sex. And both are correct. And this is the updated classification of European Society of Pediatric Endocrinology for short stature. Short stature is classified into either normal variants or pathological causes. The normal variants include familial short stature or constitutional delay in growth and puberty. Pathological causes include either primary growth failure, secondary growth failure, or idiopathic short stature when we cannot find a cause. Primary growth failure includes skeletal dysplasias, small for gestational age, syndromes like Turner, Noonan, and Prader-Willi syndrome. Secondary growth failure includes any chronic systemic illness, chronic undernutrition, endocrinal factors, metabolic, psychosocial, and drugs, and on top of the list is corticosteroids. And please remember that the normal variants are much more common, and the pathological causes are less common. So always exclude the normal variants before jumping to the diagnosis of pathological causes. And let me show you the hormones affecting growth in different periods of life. During intrauterine period, the most important is insulin growth factors and insulin. And please remember that growth hormone has no role in utero, and that's why growth hormone deficient children are born normal. During infancy, the most important is proper nutrition and thyroid. During childhood, growth hormone, IGF-1, thyroid hormones, and lastly, insulin. And in adolescence, we have a synergistic effect of sex steroids and growth hormone. So different hormones affect growth in different age group. At certain period of life, a hormone will be taking the upper hand, and then other hormones recede back, and so on. So not every hormone is important in every phase of life. So how do we diagnose short stature? We need careful history and clinical examination, oxological assessment, pubertal assessment if the child is above the age of 10, and investigations. And so we need to set a general plan for the diagnosis of short stature for proper awareness of the cause of growth failure upon which the treatment depends. And so we need to enter into more details on the diagnosis of short stature. The clinical assessment involves history. You ask about the exact age of the child, the perinatal history, past history of chronic illness or drugs, the school performance, the psychological status, and the family history is very important. Oxological assessment, you measure the weight, the height, and you plot them on the growth chart, the growth velocity, the upper to lower segment ratio, and the midparental height. Again, pubertal assessment above the age of 10. Investigations, we start by the baseline investigations, CBC, ESR, liver functions, kidney functions, calcium, phosphorus, alkaline phosphatase, urine and stool, celiac screening, antibodies, and don't forget to do a karyotype for any short girl, even if she's not dysmorphic. If all of these are normal, we do endocrinal assessment, thyroid functions, growth hormone provocation test. You must do 2 different tests. Sometimes IGF-1 and binding protein, and if you are suspecting Cushing, you will do cortisol and ACTH. Don't forget to do a bone age, And sometimes we do MRI, cella turcica, if there is panhypopituitarism and we are thinking of a tumor. What about treatment of short stature? It's simply according to the cause. And this brings me to a very important question. Is growth hormone therapy approved for any child with short stature? The answer is a very big no. It's not just giving growth hormone to any short child. We should select the cases according to each case. And this is a list of the FDA-approved indications of growth hormone therapy, growth hormone deficiency, of course, Turner and Noonan syndromes, small for gestational age who fail to catch up by the age of 2 and some say 3, chronic renal disease, Prader-Willi syndrome, idiopathic short stature, short bowel syndrome, adults with growth hormone deficiency, and AIDS wasting. So this was a very short review, and now I'll show you some short stature cases to look at the practical approach and management. And here, these are real cases that I have seen. Short stature was the clue for the final diagnosis, and please try to make it interactive. Let's try to diagnose and treat those children. Some are common variants, some are primary, and some are secondary. The first case is Yusuf. He's a 13-year-old boy. He was very much shorter than his peers, -4. He had delayed puberty, tenor stage 1. Testicular size is very small, although he is 13. Normal IQ, psychologically upset, of course. He's very short. His father was short and had delayed puberty, but he catched up his height after puberty without treatment. And this is his chart. He was normal at birth, and then he began to be short child. And then more height deceleration occurred at the time of puberty. Routine labs, celiac screen, thyroid, and growth hormone were normal. And look at this clue. The bone age was delayed 10 years, and the height age was 10 years as well. So we have a bone age exactly equal to the height age. What's your diagnosis? Yes, constitutional delay in growth and puberty. It's a clinical diagnosis. So this is how we calculate the height age. The boy is 135. We draw a line touching the 50th centile or median, and then another line down consistent with 10 year. So the boy's height is of a 10-year-old, although he is 13. This is his height age. The boy was psychologically upset, so we decided to start a very low dose of sex steroid to induce spurt. But this is not the usual. We usually wait on those children until they catch up, except if there is psychological upset. So he started his spurt, he grew very well, and now he reached a very good final height. Our conclusions are, constitutional delay in growth and puberty is a common cause of short stature. Please think of it first. Much more common in males. A positive family history of short stature and delayed puberty is usually present. Patients must have a delayed bone age, and the clue is the bone age is equal to the height age. Patients are clinically free, and you will find all the labs normal. Patients reach a normal final height without treatment. Reassurance is very important. If the patient is upset, you give sex steroid. The second case is Ziad. He's a 5-year-old boy with proportionate short stature. He's very short, less than -4, sparse hair, dull faces, normal IQ and psychological state. And look at this boy, he was normal at birth. And then he started to decelerate at the age of 3 years. Okay? Routine labs, celiac screen, thyroid is normal, but the bone age is very much delayed. What's next? What shall we do? What would you like to do for this boy? We did all the labs, all the endocrinal, except one thing. Yes, we decided to evaluate the growth hormone IGF axis. Growth hormone by clonidine and insulin was low. IGF and binding protein was low. So he has got low growth hormone, IGF and binding protein. The child has got growth hormone deficiency. If we look at the growth hormone IGF axis, the hypothalamus secretes growth hormone releasing hormone, which stimulates pituitary to produce growth hormone. On the other side, somatostatin inhibits anti-pituitary secretion of growth hormone. The growth hormone then at the liver secretes IGF-1, and growth hormone exerts a negative feedback at the level of pituitary and hypothalamus. Again, IGF-1 has a negative feedback at the level of pituitary and hypothalamus, and somatostatin has a positive feedback. So if we need to see the pathophysiology of growth hormone deficiency, it could be at the level of hypothalamus, pituitary, or liver. And this is the molecular mechanism of growth hormone action, the wall of the liver cell, and this is the liver cell membrane. The growth hormone receptor is formed of 2 parts, extracellular, transmembrane, and intracellular portions. This is how the growth hormone molecule binds. When it binds, the two parts come close together, what we call dimerization. And then JAK2 protein binds with addition of phosphate group, binding with what we call STAT protein, phosphorylated, enters the nucleus, causing release of IGF-1 into the circulation. And IGF-1 is the one which exerts the growth-promoting action on the growth plate, of course. Now, let's go back to our case. We decided to give the child growth hormone, and it's very nice when you give a child with growth hormone deficiency, growth hormone, the response is really beautiful. The child gained very good height and is doing very well. And so the lessons we learned from this case are, patients with growth hormone deficiency are born with normal length, and they have normal growth velocity during infancy, because we said growth hormone has no role in utero. Growth hormone deficiency is diagnosed by 2 growth hormone provocation tests, and this is a very important message. Don't ask for basal growth hormone. It has no value. Response to growth hormone therapy is usually adequate when started early. As soon as you diagnose, start. The third case is Mariam. She's a 13-and-a-half-year-old girl with short stature, -3.5. She has delayed puberty, breast stage 1, slightly dysmorphic, not so much. She had a low birth weight and low birth length with swelling of the dorsa of hands and feet, as you see. And the mother noted clear mathematical problems at school for this girl. And this is her chart. She was short since birth, during infancy, childhood, and adolescence. Routine labs, celiac screen, thyroid, growth hormone, everything was normal. The bone age was delayed. Echo was done because she is dysmorphic. It was normal. Ultrasound abdomen showed partial horseshoe kidney, so she has renal anomaly. What else is missing in this girl? What's the missing investigation here? Yes, karyotype. Yes, excellent. So karyotype revealed a 45X Turner syndrome girl, and here we started growth hormone and sex steroid, and she catched up her height and puberty very well. But unfortunately, she started to plateau again. Something happened again after she improved. Okay, and then we decided to re-evaluate Mariam. Her routine labs were normal, celiac screening was negative. But this time, when we repeated the thyroid function, she had a low T4, high TSH, primary hypothyroidism. And in Turner's, they are very liable to autoimmune disease. We did the thyroid antibodies and they were positive. So there was also 4 years delay in the bone age, even worse. She developed autoimmune hypothyroidism, and here we added L-thyroxine, and the girl is doing very well now and catched her height and puberty. And to wrap it up from Mariam's, karyotype must be done to any short girl, even if not dysmorphic. Karyotype must be done to any girl with edema of the dorsum of the hands and feet. Short stature and delayed puberty are cardinal features of Turner syndrome. Turner girls could have normal growth hormone level because sometimes they have resistance and not deficiency. Therefore, they need higher doses of growth hormone. And Turner girls are more liable to autoimmune disease like celiac and Hashimoto's. So please, if you find that she's not responding, screen for autoimmune disease. The presence of associated untreated autoimmune disease weakens the response to therapy. So if the child is not responding, search for autoimmune disease. The fourth case is Ahmed. He's a 9-year-old boy who was growing very well until 5 months ago. He started to slow down his growth. He is short, but not very short, because it's not a long time, -2.5. He had squint, deteriorated vision with bitemporal hemianopia, projectile vomiting, headache, and a clear deterioration in the school performance. And this is the chart. Remember that he was completely normal. He was completely normal child since birth and childhood. But then 5 months ago, secondary growth failure occurred. He stopped to grow. Routine labs showed some anemia, celiac screening negative. Look at the thyroid function, low T4, low TSH. This is central hypothyroidism, something in the brain. Growth hormone by 2 tests low. We have growth hormone deficiency. And the bone age was a little bit delayed, not too much because it's not a long time. So it looked like panhypopituitarism. And the golden rule is whenever you have more than one pituitary defect, you must search for the other hormones. And this is what we did. Cortisol, ACTH were low, central hypoadrenalism, sodium, potassium normal. We did not assess FSH and LH because the child is prepubertal. So it is definitely acquired panhypopituitarism. What is the next urgent investigation? Yes, MRI. This was very big cystic craniopharyngioma, as you see here, confirmed by histopathology. And he was fortunate. The tumor was resected on time, and hormone replacement therapy was given, and the child is doing very well now. The conclusions are a child who was growing well and started to have a poor growth velocity must be thoroughly investigated. Please respect secondary growth failure. Tumor or chronic illness, craniopharyngioma is rare, but it's the most common brain tumor in children. And any case of panhypopituitarism must perform MRI because it could be hiding a serious tumor. The last one is Khalid. He experienced rapid weight gain, obesity, fatigability, bruising, with no history of drug intake. As you see, he has got moon face, facial plethora, and hypertension. This is his height and this is his weight chart. He had normal growth, and then he started to have secondary growth failure and rapid weight gain. So we are facing a case of obesity and short stature. Here, the CBC showed polycythemia, borderline low calcium, and impaired fasting blood sugar. And here you can see impaired circadian rhythm. Cushing's syndrome was suspected, and it was confirmed by a lot of labs and dexamethasone suppression test, and it looked like adrenal Cushing. We have seen a mass by ultrasound, confirmed by CT scan here, as you see at the arrow, and this is a very huge tumor extracted from the boy after surgery was done, confirmed by PAS-positive signature adrenal carcinoma. Cushing was cured, and the boy started to lose weight and to gain height, which was very good. And this is the boy, how he looked like 1 year after excision of the tumor and treatment. Don't just look at the weight and height, look at the mood. Look how the boy looks happy and safe. And the conclusions here are, if you have an obese child with normal height, think of simple obesity. If you have obese child which is short, exclude endocrine and syndromic obesity. Any obese short child must be thoroughly investigated and highly respected. Don't just put the child on a diet. And let me end by a very important historical note. Short stature did not prevent dwarfs in ancient Egyptian culture from attaining high positions in society. Some served as assistants to the pharaoh, and others were looked up to as gods. This is the statue of Bess في الفيلم بتاع عادل إمام إله الحب. He looks very ugly, بس هو ده إله الحب عندهم يعني. وفي المتحف في الكايرو museum, a lot of achondroplasia patients and panhypo patients, I was surprised to find them. يعني كان في زي endocrine section هناك الحقيقة مليان حاجات زي كده، كانوا متقدمين قوي. And let me show you the tallest and the shortest man in the whole world. This is the Italian man, 2.52 meter, Sultan Kozan, and this is the shortest man in the whole world. He's 53 centimeters. He's like a newborn. And Kozan said, even though he's short and I'm tall, we have had similar struggles throughout our lives. And let me tell you that most of the world leaders are short, with the exception to Barack Obama, but the rest are really short. They are lucky people. But short stature could be a problem. The French president, Nicolas Sarkozy, stands on a chair when giving a public speech. Although he is the president of a big country like that, he feels that he is short. And he asks his pretty tall wife not to wear high heels. She cannot wear high heels, okay? Because he feels that he is shorter. So what? Short stature could pose a really heavy psychological burden on those children and affecting the quality of life of these children, which is really important. And it could be the key to diagnosing a serious medical problem as what you have seen, a tumor, a chronic illness, or even more. And thus early diagnosis and treatment of short stature helps to optimize the final height and to improve the quality of life, which is, again, very important for those children. And my final conclusion is children with short stature should be referred, diagnosed early in order to offer proper therapy at the proper time for those patients. And in order to do this, we need to reach the proper diagnosis by working in a team, because those children usually go to the pediatrician, not to the pediatric endocrinologist. It's really important to cooperate together to fit the pieces of the puzzle in those children in order to help them reaching the proper diagnosis and offering proper treatment at the proper time, which is, again, very important and which goes to our final target. And I really love this word. It affects me a lot. Better growth changes the future. I have a lot of children who refuse to go to school, although they are brilliant, because they are teased by their classmate, you are short. A lot of children who were champions in sports, who were kicked out of the team because they are short. Some of them are really brilliant. It's not a fatal disease like leukemia or renal failure, but it's really important to keep our children growing well, because again, better growth changes the future. And thank you very much for your attention.
بنشكر أستاذتنا الرائعة والمتألقة دايما. بصراحة أنا يعني أتحدى أن احنا نشوف بروفيسور بهذا الهاي لانجويستيك بيرفورمانس. الاودينس كلهم مركزين، مفيش كلام عربي في النص، بس شوفوا الروعه اللي بيسموها المعادله المستحيله مش الصعب. بنشكر الدكتور رشا على المحاضره الجميله دي، وخلاص في بريك جاي.